Hey everyone, welcome back to Shock Doc Medical. I'm Dr. Rod, and today we're diving deep into a topic that hits home for parents and pediatricians alike: fever and rash in kids. Have you ever wondered how a seemingly simple rash can hold the key to diagnosing everything from common viral infections to life-threatening conditions? Buckle up, because we're about to unpack a whole chapter on pediatric exanthems, and trust me, you're going to want to stick around for every detail. Picture this. Your child comes in with a fever and a rash, and while most of these rashes are self-limited and resolve in about 7 to 10 days with just symptomatic treatment, sometimes there's a lot more happening under the surface. Vaccinations have slashed the cases of measles, rubella, and chickenpox, but outbreaks still pop up, especially among unvaccinated populations. Today, we're going to break down every angle of this subject so you, as a parent or a fellow doctor, have the complete picture. Let's start with the basics. Fever and rash in kids are often tied to bacterial and viral infections. Most of these conditions have distinct patterns and telltale signs. The key is to look at the history and the pattern of the rash, its timing, color, distribution, and even whether it comes with an enanthem. That's a rash inside the mouth or on the mucous membranes. Think of it like solving a mystery. Every clue can point you toward the right diagnosis. And while many of these conditions are self-resolving, some demand prompt action. When you see a child with a rash, ask yourself, was there a prodrome, a period of fever or other symptoms before the rash appeared? Did the rash follow a specific pattern? For example, a rash that starts at the head and works its way down, what we call a cephalocaudal distribution, is a classic hallmark of diseases like measles and rubella. And sometimes rashes can be unilateral or only show up in dependent areas, like in Henoch-Schönlein purpura or unilateral laterothoracic exanthem. These details, the color of the rash, the primary lesion, any desquamation, that's peeling or swelling, are crucial for making the right call. Now, most of the time, a careful history and physical exam give you the answer. But if you're scratching your head, serologic blood studies can be super helpful. A skin biopsy is rarely needed, except in specific cases. Think erythema multiforme or Henoch-Schönlein purpura. And if you suspect varicella or chickenpox, you can use PCR, a direct fluorescent antibody test, or even viral cultures to confirm the diagnosis. Remember, if the child has prolonged fever with an unknown source, always consider Kawasaki disease. And don't forget about vaccine-preventable diseases in the unvaccinated or immunocompromised. All right, let's break down some of the common viral causes. Measles, rubeola, history and prodrome. Incubation is around 8 to 14 days with fever, cough, coryza, and conjunctivitis. Rash details. Erythematous macules and papules appear along the scalp, hairline, and behind the ears, spreading downwards over 4 to 7 days. Keep an eye out for Koplik spots on the buccal mucosa. Complications: otitis, pneumonitis, encephalitis, myocarditis. Labs: look for a 4-fold increase in IgG titers, rapid IgM assays, PCR, and ELISA. Varicella chickenpox, history and prodrome, incubation of 10 to 21 days with mild malaise and low-grade fever, usually seen in late fall, winter, and spring. Rash details, characterized by teardrop vesicles, often described as dew on a rose petal, with lesions in various stages. In immunocompromised patients, be wary of disseminated disease and secondary infections. Complications: Rey syndrome, especially with aspirin use, and congenital varicella can lead to hypoplastic limbs. Labs: clinical diagnosis is often enough, but PCR, DFA, and antibody titers, IgM and IgG, can confirm. Cytomegalovirus, CMV. History: in immunocompetent children, postnatal CMV is often asymptomatic or resembles mononucleosis. Rash details: diffuse erythematous macules and papules, sometimes with mucosal ulcerations. Complications: congenital CMV may lead to the blueberry muffin. Appearance: hearing loss, seizures, and intracranial calcifications. Labs: urine virus isolation, serologic tests, antigen detection, and PCR analysis are key here. Mononucleosis, EBV. History: incubation of 30 to 50 days. Prodrome includes fever, sore throat, lymphadenopathy, and malaise. A rash might appear following the use of amoxicillin. Rash details: often a morbilliform rash covering the body with periorbital edema and petechiae on the palate. Labs: look for leukocytosis with 50% lymphocytosis, elevated liver enzymes, and use the monospot test, though it can be less reliable in kids under 4. Rubella, German measles. History: Incubation of 16 to 18 days with a prodrome of fever, headache, and upper respiratory symptoms. Rash details: rose-pink macules that spread in a cephalocaudal fashion, often accompanied by soft palate petechiae, Forsheimer spots, and posterior auricular lymphadenopathy. Complications: major concerns include congenital rubella syndrome, deafness, cataracts, congenital heart disease, as well as hepatitis and arthritis. Labs: diagnosis is confirmed via IgM antirubella antibodies or a fourfold increase in IgG. Roseola exanthum subidum. History: caused by HHV6 with an incubation of 5-15 days. High fever for 2 to 3 days precedes the rash. Rash details: erythematous, blanchable macules and papules, often with periorbital edema. The rash appears as the fever subsides. Complications: watch for febrile seizures. Labs: confirm with ELISA or PCR. Parvovirus B19, fifth disease. History: incubation of 4 to 14 days with a prodrome of headache and fever. Rash details: the classic slapped cheeks appearance, followed by a lacy reticular rash that can wax and wane over weeks. In adolescents, you might see papular purpuric gloves and socks syndrome, and adults can present with arthritis. Complications: hydrops fatalis and aplastic crises in patients with sickle cell disease. Labs: typically diagnosed clinically, but serologic tests for anti-B19 IgM and IgG, along with PCR, can be used. Hand, foot, and mouth disease. History: most commonly caused by Coxsackie A16 with an incubation of 3 to 6 days. Rash details: macules evolve into vesicles on a red base, particularly on the palms, soles, and oral mucosa, often painful and quick to erode. Labs: testing is usually not needed, though PCR is available. Giannotti-Crosti syndrome, acrodermatitis of childhood. History: often linked to hepatitis B in developing countries and EBV in the US, seen mostly in 2-year-olds, range 6 months to 14 years. Rash details: a symmetric papular eruption on the face, buttocks, and extremities. Those papules are described as pink to erythematous and quite juicy. Labs: evaluate for a specific viral etiology if indicated. Unilateral laterothoracic exanthum. History: typically affects kids aged 6 months to 10 years and is often preceded by URI or GI symptoms. Rash details: starts in a unilateral axilla and spreads in a centrifugal pattern with erythematous papules and plaques that may have a scaly urticarial appearance. Nonspecific viral exanthum. History: caused by non-polio enteroviruses in the summer and respiratory viruses in the winter. Rash details: presents with blanchable erythematous papules and macules diffusely over the trunk and extremities, sometimes affecting the face. Labs: usually, no tests are required, though enterovirus cultures from the throat or stool can be done. Moving on to the bacterial causes, which can be even more urgent. Scarlet fever. History and prodrome. Caused by group A beta hemolytic streptococcus producing pyrogenic exotoxins. Incubation is 1 to 4 days with fever, chills, sore throat, and headache, classic strep pharyngitis symptoms. Rash details: look for a fine sandpaper-like rash with erythematous papules and macules accentuated in flexures and a strawberry tongue following a white coating that sloughs off. Labs: throat culture is the gold standard, with rapid strep tests offering high sensitivity and specificity. Treatment: typically, we treat with penicillin V, for example, 250 milligrams orally every 8 hours for children under 27 kilograms for 10 days, or amoxicillin 50 milligrams per kilo a day divided every 8 hours for 10 days. Staphylococcal scalded skin syndrome, SSSS, or Ritter's disease. History: rapid onset of fever, malaise, irritability, and poor feeding, followed by generalized tender erythema. Rash details: tender, erythematous lesions, often starting with flexural and perioral accentuation, quickly evolving into superficial blisters that rupture easily. The Nikolsky sign is positive. Labs: cultures from pyogenic foci, like the conjunctiva or nasopharynx, help in identification. Treatment: in severe cases, IV nafcillin or oxacillin is used, commonly dosed at 50 milligrams per kilo a day, divided every 6 hours, with adjustments if MRSA is suspected, where vancomycin might be used instead. Toxic shock syndrome, TSS. History and prodrome. Presents with a prodrome of malaise, myalgias, and chills, progressing rapidly to fever, lethargy, diarrhea, and altered mental status. Rash details: a diffuse scarlatiniform rash that later desquamates. Palms and soles are involved, with accentuation in skin folds and sometimes only localized involvement in the inguinal or perineal regions. Labs: Multi-organ involvement is key, and lab findings might show leukocytosis, anemia, thrombocytopenia, elevated creatinine, hypocalcemia, and abnormal liver function tests. Treatment. Management is both supportive and antibiotic-driven. We often use a combination of clindamycin, 10 to 13 milligrams per kilogram dose IV every 8 hours, plus vancomycin, dosed appropriately based on weight and renal function, and sometimes IV immunoglobulin if indicated. Meningococcemia. History. Caused by Neisseria meningitis with an incubation of 2 to 10 days. The presentation can range from a mild fever to fulminant disease with meningitis. Rash details. Petechial rash on the skin and mucous membranes that can progress to purpura fulminans with sharply marginated patches and even necrosis. Labs. Blood and CSF cultures are key, along with PCR and serologic testing for capsular polysaccharide antigens. Treatment. Immediate treatment with IV penicillin G is crucial. For example, 200,000 to 300,000 units kilograms per day divided every 4 to 6 hours, alongside supportive care. Urticaria multiforme. History. Often follows an upper respiratory or viral infection, with an abrupt onset of annular erythematous wheals that have central clearing. Rash details. Widespread, often with hand and foot edema, and sometimes lip swelling. Labs. Skin biopsy can help if there's diagnostic uncertainty. Treatment. Typically managed with supportive care and antihistamines. Diphenhydramine at 1 milligram kilogram dose every 4 to 6 hours as needed works well. Serum sickness-like reaction. HISLR. History. Usually occurs 1 to 3 weeks after starting an offending drug, most commonly cefaclor, though amoxicillin or griseofulvin can also be culprits. Rash details. Targetoid or annular to polycyclic erythematous plaques with a characteristic violaceous center. Labs. Unlike true serum sickness, you won't see immune complex-mediated vasculitis here. Treatment. Stop the offending drug immediately. Supportive care is key. In more severe cases, a short course of prednisolone at 1 to 2 milligrams per gram per day may be considered. Erythema multiforme. History. Often triggered by herpes simplex virus, mycoplasma, or medications. Rash details. Classic targetoid plaques that are persistent and typically involve the palms and soles. Labs. HSV titers and cold agglutinins for mycoplasma can aid the diagnosis. A skin biopsy is diagnostic if needed. Treatment. Supportive care is standard. If HSV is involved, acyclovir may be used. For example, 10 milligrams kilogram IV every 8 hours in severe cases. Henoch-Schönlein purpura, HSP. History. A small vessel vasculitis that usually affects children between 2 and 11 years, often following an upper respiratory infection. Rash details. Begins as urticarial lesions that quickly become purpuric, predominantly on the lower extremities and buttocks, with common scrotal involvement and edema of the hands, face, and feet. Labs. IgA immune complexes and direct immunofluorescence can support the diagnosis. About 1/3 of patients have elevated serum IgA. Treatment. Mostly supportive, but in severe cases, prednisolone at 1 to 2 milligram kilograms per day can be considered. Kawasaki's disease. History. An acute febrile mucocutaneous lymph node syndrome, most common in children under 5 years, especially under 2, often occurring in winter or spring. Rash details. To diagnose, you need at least 4 of the 5 criteria. Fever for more than 5 days, palmoplantar erythema or desquamation, conjunctivitis, a strawberry tongue with fissured and crusted lips, and cervical lymphadenopathy. The rash is polymorphous, maculopapular, targetoid, or scarlet fever-like with accentuation in body folds. Complications. The big one here is coronary artery aneurysms and other cardiovascular issues. Labs. There's no definitive test. Diagnosis is clinical. Treatment. Prompt treatment is essential. Standard therapy is intravenous immunoglobulin, IVIG, at 2 gram per kilogram as a single infusion, along with high-dose aspirin, typically 80 to 100 milligrams per day, divided into 4 doses while febrile, then transitioning to a low dose of 3-5 milligrams per kilogram per day for its antiplatelet effect. Now, why is all this so important? Because behind every clinical sign and lab value is a child and a family counting on us to get it right. When we're able to recognize these patterns early, we can provide the appropriate care, and in some cases, even prevent serious complications. I remember a case early in my career where a delayed diagnosis of Kawasaki's disease nearly cost a child his heart. It's these experiences that drive home the importance of staying sharp, asking the right questions, and not dismissing any detail, even something as simple as the pattern of a rash. So there you have it. a comprehensive tour through the world of fever and rash in children. We covered everything from viral exanthems like measles, varicella, and roseola to bacterial challenges such as scarlet fever, staph scalded skin syndrome, and even the serious Kawasaki's disease. Whether you're a parent, a medical student, or a seasoned clinician, I hope this breakdown helps you understand what to look for and how to act swiftly when these conditions arise. If you found today's deep dive helpful, please hit that like button, subscribe to Shock Doc Medical, and share your thoughts or any questions in the comments below. Let's build a community of curious minds and passionate caregivers who are committed to staying informed about the latest in medical breakthroughs. Stay tuned, because next week we're going to explore another groundbreaking topic that might just change everything you know about pediatric care. Until then, I'm Dr. Rod. Stay curious, stay compassionate, and keep learning.